So we're going to talk a little bit about cervical disc replacement. First, I want to go over who really needs cervical spine surgery. So typically, our most common patients who have cervical radiculopathy. That is a pinched nerve in the neck. Typically, when patients fail physical therapy and anti-inflammatories, they become a candidate for potential surgery. The pinching of the nerve can occur typically due to two main problems. As you can see on the left there, you can have bone spurs that can pinch the nerve as it exits the spine. Or on the right, you can have a disc herniation that pinches the nerve as it exits the spine. A lot of times people will have a combination of both things. When the nerve is pinched, we typically see a pattern of pain depending on which nerve is being affected. Typically, a lot of these nerves also are responsible for motor function in the upper extremity, and so you can see weakness in certain muscle groups. A second common group of patients that we see that need surgery are patients with cervical myelopathy. That is, patients who have a pinched spinal cord. These patients will present with more vague symptoms. So symptoms such as hand numbness, fine motor difficulties, difficulty with weakness, balance problems, and in very severe cases, bowel and bladder issues. This is a patient who had a large disc herniation who presented with severe myelopathy acutely due to pinching of the spinal cord. So traditionally, anterior surgery through the neck involves removing the disc and the bone spurs that are pinching the spinal cord and the nerves and creating a fusion. The clinical problem, however, is what we call adjacent segment degeneration. That is, added stress to the level above and below the level of fusion, which causes it to develop arthritis and break down earlier than it normally would. As you can see here, this is a patient who underwent a successful fusion at C6, C7, and has started to develop pretty significant arthritis at the level immediately above. This is an unfortunate patient who had a fusion at C6, 7 and developed arthritis both above and below the previous fusion, requiring multiple revision surgeries. The theoretical basis is that when you have a solid construct, you change the biomechanical properties of that area, and you cause added strain and stress to the level above and below, causing it to develop arthritis much more quickly than it would otherwise. Cervical disc replacement is a potential solution. You remove the compression on the spinal cord and the nerves as usual, but then you work to maintain motion at that segment so that you can prevent adjacent segment degeneration. This is a patient who underwent a successful cervical disc replacement, and as you can see, when they bend forward and bend back, the implant actually moves with their neck. When can you do it? Well, this is a lot of data over here, but essentially what it shows is that the indications for a cervical disc replacement are much more narrow than for a cervical fusion. In fact, in this study, 186 patients who were candidates for anterior cervical surgery, only about 10% of them were candidates to actually have a replacement done. In my eyes, it's typically one-level disease, maybe two-level disease. You have compression of the spinal cord or nerve root, and you have minimal bone spurs, minimal neck pain, and minimal arthritis. This is a perfect candidate for a cervical disc replacement. As you can see on the x-rays on the left, which is a side view of the spine, they have minimal arthritis in their spine. They have good-looking discs. On the MRI in the middle, you can see there's a pretty central disc herniation that is pinching the spinal cord. And on the right, you can see that there is a successful cervical disc replacement that was done. More often, we're also seeing some off-label use of these constructs, namely combining a cervical disc replacement with a fusion. This is typically in patients who have one level where there's a lot of arthritis that is not amenable to replacement, and another level where there's minimal arthritis where certainly you can do a replacement. The jury is still out on whether these hybrid constructs actually have any merit, but this is something we do see more often. Typically, surgery is outpatient or done as a 23-hour stay under general anesthesia. You have a small incision on the front of your neck, and the disc is accessed at the particular level and removed. Once the compression is removed on the spinal cord and on the nerves, we use x-ray guidance to get a visual of the disc space where we are working, and then set up the disc space to implant the implant that's going to be placed there. Unlike traditional anterior cervical fusion, we use a lot more x-ray during this procedure because the implant has to be placed pretty precisely. As with all of orthopedics, there's a ton of implants out there that are going to be amenable to solving this problem. They all have different motion mechanisms, but the premise is the same. Maintain motion at this segment so that you do not create abnormal stresses at the other levels. Does it work? Well, early studies were very good, and they showed significantly decreased rates of adjacent segment degeneration, decreased rates of revision surgery, and greater cost effectiveness for disc replacement. Unfortunately, as we go more long term, and these are more recent studies looking at data about 7 to 10 years out, we're finding out more and more that actually the results are pretty similar. Most of these studies show a trend towards decreased adjacent segment degeneration, but a lot of them do not show statistical significance. Now, unlike our joint replacement colleagues, our spine surgeons are not savvy enough to develop registries, and so I think if we had more numbers, we could probably give a more accurate answer. So when we ask, does it work, we don't really know. What can go wrong? Well, when you do surgery on the spine through the front of the neck, there's a lot of things that can go wrong. But when you do replacement in particular, we still don't know how these implants are going to perform over the long term. We don't have the data yet. They've only been out about 10 years. As you can see on the bottom left, this patient underwent a 2-level cervical disc replacement and actually wound up developing further arthritis at those 2 levels, requiring surgery from the back at a later time. The patient on the right had a cervical disc replacement that unfortunately eroded through the bone and required removal of the implant as well as a posterior fusion. And then occasionally we do see cases like this, which is a cervical disc arthroplasty that completely eroded through the bone into the spinal canal, pinching the spinal cord and causing acute paralysis. The implant was removed, and unfortunately this patient did not really regain much function. So in conclusion, for certain cervical pathologies, cervical disc replacement offers a motion-sparing alternative to traditional fusion, and in doing so can decrease the rate of adjacent segment degeneration. Unfortunately, earlier term data showed us that this was a pretty good procedure. Our longer term data is not quite as robust. And as anytime you do surgery on the cervical spine, implant-related complications are rare, but when they do happen, they can have some catastrophic consequences. Thank you.